All right, I'll finish up this week's presentations and the discussion of common breast complaints by talking a little bit about the topic of breast masses and cancer. I'm going to kind of put out a disclaimer there. When we talk about breast cancer, there is so much research going on right now. And right now there's something like over 400 clinical trials going on to test and evaluate different treatments for breast cancer. That to give you a presentation or a lecture on the treatment of breast cancer would be very misleading, because although it is a highly treatable cancer, and certainly our recovery rate or our survival rate is much better than it used to be, much, much better, we're still doing a lot of research on breast cancer. So to try to tell you that I'm up on the latest and the greatest, I can't tell you that. But when we care for patients with breast cancer, we will probably be caring for those patients in the primary setting for their other primary care issues and not their breast cancer, because once most women have breast cancer, they prefer to go back to their treatment center, wherever that may have been, for all of their follow-up, which of course is very appropriate in the way that it should be. The same with once we have palpated a breast mass and anything that is suspicious beyond probably a cyst or fibrocystic breast changes most commonly, then we're going to refer that out and let those who specialize in breast disorders take care of the patient as far as any additional follow-up and treatment, and even some of the diagnostics beyond the diagnostic mammogram or perhaps the ultrasound. So having said that, let's get started with common breast complaints, breast masses, and cancer. Okay, the classification of breast masses is, now before getting into the actual classification, I do want to emphasize that a palpable breast mass is considered dominant, meaning highly suspicious, if there is a three-dimensional lesion that's distinct from the surrounding tissues and it's actually asymmetric relative to the other breast tissue. So when we have a mass that meets that criteria, it is three-dimensional, distinct from the surrounding tissues, and you find asymmetry. Now you've identified a breast mass is present, and now you have to decide whether this is a highly suspicious breast mass that needs an immediate diagnostic workup and referral, or if it is a simple cyst that you can watch from a distance, or not from a distance, but that you can watch if you're very, very comfortable this is a cyst, and then just reevaluate it. So in classifying masses and those that actually meet that criteria of a palpable breast mass is the cyst, and that can be broken down into simple and complex. The proliferative lesions that are without atypia, including meaning atypical cells, which of course are either dysplastic cells or even the cancer cells themselves. So we have the proliferative lesions without atypia, including the adenoma and, well, the ductal hyperplasia, intraductal papilloma, and then the atypical hyperplasia, which is the ductal and the lobular. So we'll talk a little bit more about all of these classifications. But starting with fibrocystic changes. Now, fibrocystic changes we've already talked about a little bit in conjunction with mastalgia. Fibrocystic changes typically are associated with nodularity or thickening rather than an actual discrete three-dimensional mass. The fibrocystic changes are so common that they're no longer called fibrocystic breast disease, instead fibrocystic changes. The cystic breast mass may occur at any age. They fluctuate with the menstrual cycle. They are the most common of all of the benign breast diseases, and most common between the ages of 20 and 50. May present with bilateral cyclic pain, breast swelling, palpable mass, and heaviness. In fact, that is the common presentation. Physical examination will elicit tenderness of the breasts. Especially remember that tenderness is going to be in that luteal phase or the premenstrual phase. There is an increased lumpiness. It's rather glandular, and with the fibrocystic changes, you may actually have some occasional spontaneous nipple discharge. In premenopausal women, it is very important that we get a history of changes in the mass with the menstrual cycle, and that needs to be determined that, yes, the mass changes with the menstrual cycle. And we're also going to do a thorough examination of the breasts to determine the size as well as the mobility of the fibrocystic changes. Okay, this is actually an adaptation from your textbook on the various benign breast masses. The most common are going to be the fibroadenoma and the cyst, with the lipoma, fat necrosis, the phyllodes tumor, hematoma, and galactocele all being less common. And the only two that I'm going to talk about in this presentation will be the fibroadenoma, which is a discrete, smooth, round or oval, non-tender mass, which is also, as I said, mobile. And then upon tissue sampling, we find ductal epithelium, dense stroma in the fibroadenoma. The cyst is discrete, it's tender, it's mobile, the size fluctuates with the menses, and with tissue sampling, we find cyst fluid and inflammation. Benign breast masses, and talking more in terms of the fibroadenomas, these are dense epithelial and fibroblastic tissue. They're non-tender, they're encapsulated, they are round or sometimes oval in shape. These are movable, and that's why you always are going to document mobility of breast masses. And they're very firm, which you would expect in any mass that is encapsulated. These smooth masses are most common in adolescents and young women. However, 12% of the masses in menopausal women are actually the fibroadenomas. In 10 to 15% of women, we actually find multiple fibroadenomas, and it's believed that the etiology of fibroadenomas is the effect of estrogen in susceptible tissue. Okay, cysts are fluid-filled masses. They are most common between the ages of 35 and 50, and this is the ultrasound of a breast that has this fluid-filled breast cyst. Management of palpable masses. So a patient presents to your clinic, and with either they've found a palpable mass or you're doing a general physical exam or a well woman exam, and you palpate a three-dimensional mass. So what are you going to do about it? This again comes from one of your required readings. you're going to always, just as you did with your mastalgia, just as you did with your nipple discharge, just as you did with the breast infection or inflammation, you're going to obtain a thorough breast history and perform a clinical breast examination. If your examination suggests no mass, then you have the patient return to the clinic in 2 to 3 months and you repeat your clinical breast exam. If the clinical breast exam and your history determine that there's or suggest an indeterminate lesion, if the patient is younger than 30 years of age, then the diagnostic workup is going to be a directed ultrasonography. However, in those cases where the examination suggests an indeterminate lesion, the patient is over 30 years of age, we're going to order diagnostic mammography with or without the directed ultrasound. So when you're ordering your mammograms, if it's just a routine mammogram, you order that as a screening mammogram. When you're ordering a mammogram because you have a suspicion of a problem being there, such as you have a breast mass, you're going to change that and it will not be a screening mammogram, it will be a diagnostic mammogram. A big difference between the two, now, well, one is they're going to get additional views with the diagnostic mammogram. But number two is you can get a patient in for a diagnostic mammogram in 24 to 48 hours in most cases. If it is a screening mammogram, they may have to wait even up to a month because this isn't considered an urgent event, but just a routine screening of the breasts. Okay, so that was the examination of the indeterminate lesion. For the mass that is very suspicious based upon the examination, you're going to order a diagnostic mammogram and directed ultrasound. And then the next step would be biopsy, which the preferred method of biopsy is now image-guided core needle biopsy. And with the core needle, they can extract both tissue as well as the fluid that it would be in this fluid-filled cyst. So if it's an indeterminate lesion, if they're younger than 30, then you're going to get the directed ultrasound. If they're older than 30, you're going to get mammography, diagnostic mammography, and with or without the directed ultrasound. This is the evidence for the diagnostic workup, which is rather interesting in that it is consistent with everything I just told you, except the evidence is consensus-based, where it's a rating of 3. It's consensus, it's disease-oriented evidence, it's the usual practice, expert opinion, or case series. So when we're looking at the evidence for the diagnostic workup, it could be better. It could be worse, but it could definitely be better. So ultrasound is the preferred imaging modality in women younger than 30 years with a palpable breast mass. Ultrasound-guided core needle biopsy is the preferred method of tissue sampling for suspicious palpable breast masses. Ultrasonography should be performed in all patients with focal breast pain with adjunctive mammography in patients 30 years and older. Now remember when we talked about mastalgia that if it is focal and unilateral in one breast, it's more suspicious of there being some type of malignancy going on there or a cancer going on there than if it is bilateral and you can't find a focal point of the pain. So when you have focal breast pain, then the diagnostic should be ultrasonography with or without the mammography. Now, I've already talked about danazol, and that really is not the diagnostic workup that I want to talk about here. So I'm going to jump down to mammography and subareolar ultrasonography should be performed in patients with nipple discharge that is spontaneous, unilateral, clear, serous, bloody, or associated with a mass. Now, all of those are those patients with nipple discharge that's suspicious that we want to do further workup on. And so if we have that high suspicion or that suspicion based upon our manifestations, then we're going to do the mammography and the subareolar ultrasound. And then, very important, that we tend to think that we have to always run the diagnostic tests, and sometimes that just isn't the case. No radiologic investigation is needed in patients with physiological discharge if routine screening mammography is up to date and physical findings are normal. So just because there is a nipple discharge, we don't necessarily, and frequently it's not indicated for us to go ahead and do x-rays, a mammogram, or an ultrasound on those particular patients. All right, breast cancer, the big C. This is a fear of many women, and it increases as a woman gets older. And we're going to briefly talk about carcinoma in situ, invasive breast cancer, Paget's disease, and inflammatory breast cancer. Each year there are about 230,000 new cases of invasive breast cancer and more than 55,000 new cases of in situ breast cancer are diagnosed in women annually. Our lifetime risk is 1 in 8 of developing a breast cancer. It is the most common cancer in women, and we know that the risk of breast cancer increases with age. We do have, the good news with breast cancer is that we do have a decreasing mortality rate attributed to earlier detection and better treatment that we now have available. When a patient presents with a breast mass, just like every other common breast complaint, we're going to get a thorough history related to the breasts, and we're going to do a clinical breast exam. History should include age, the patient's ethnicity, education, and socioeconomic status, as well as any and all changes and abnormalities of the breast and axillary lymph nodes. You should also note any systemic symptoms in this patient with a breast lump that may indicate metastasis. And finally, the medical history, GYN history, pregnancy history, and familial history of breast and ovarian cancer should also be addressed in that visit when the patient presents with a breast cancer or a breast mass that developed just shortly or something they may have been watching for a long time. Okay, breast cancer risk factors. I'm going to let you read these. It's nothing new here that I think you'll be surprised at. When they talk about early menarche as a risk factor, we're talking less than age 12. Late menopause is over the age of 55. Now, the interesting one is there seems to be a little higher risk of breast cancer when with current combined oral contraceptive use. It's really believed that this is probably because it's a bias that's been presented in the data, because the patients who are on the oral contraceptives or the combined oral contraceptives are more likely to be seeing their practitioner and getting the breast exams than the general population of women. Some others that I think are interesting, definitely the personal and family history of breast cancer and inherited genetic mutations. But that's kind of a false sense of calm that can be placed in many women, because if they don't have those personal risk factors of a personal history, family history, especially of a first-degree relative, sister or mother, especially if the patient has tested negative on genetic testing for inherited genetic mutations, this gives us a false sense of well-being and a false sense of safety, which may not be there, because by and far the vast majority of women who get breast cancer don't have the genetic mutations. Physical inactivity has been associated with increased risk factor, as had being overweight or obesity. And in this case, the belief is that when there is excess fat, the estrogen is stored in that excess fat, and then this increased estrogen will put the woman at higher risk of developing breast cancer. Okay, this is one of our diagnostic tests, and the one that's used most often is going to be the screening and the diagnostic mammogram. The one risk factor, and let's go back, one risk factor is high breast tissue density. And I just wanted to show you some differences in the mammogram of a very dense breast, as you see in this particular picture, is when the sensitivity, meaning false negatives, where you have fewer false negatives with a high sensitivity. And we know the sensitivity of mammography for detecting malignancy is significantly reduced if the breast consists of a high proportion of fibroglandular or dense breast tissue. And what that means, that the more dense the breast is, the more likely we're going to get a false negative on our mammogram, or we're not going to pick up that breast lump on mammogram due to the density of the breasts. That's compared to this next picture, which is showing a breast that is fatty in this case, but we don't have that very high density, that fibroglandular tissue that we had in the first picture. And this one is going to actually be more likely to, or we have a better sensitivity with the mammogram in the less dense breast. This is one of the reasons that with our younger women, it's not necessarily advised that we go right to the mammogram to determine the significance of a breast lump, because the younger women tend to have more breast density, and we're less likely to find a cause for a breast lump if we do the mammography, and therefore the ultrasound is at least the initial diagnostic workup of choice. Okay, your physical exam of the breasts, I want you to review that information. Remember that you're going to inspect the contour, symmetry, skin, and nipple changes of the breast. It should be performed during the follicular phase of the menstrual cycle. So if we wait till the luteal phase, it's going to be more uncomfortable for the woman. So we do it during the follicular stage when we're less likely to elicit that discomfort. You are going to inspect each breast and palpate each breast in the upright and supine positions. You're also going to do a visual comparison between the two breasts to determine if there's some asymmetry in the breasts. Obviously, you're going to document the size, location, mobility and consistency of any palpable breast mass or any dense area. You're going to describe location of nipple discharge as well as the characteristics of that nipple discharge, and you're going to check the lymph nodes in your physical exam. Pain is actually present in less than 10% of our patients with cancer, so remember, even though we may be doing a workup in this woman with breast pain, that it is very unlikely that we're really going to find breast cancer in that patient. Diagnostic imaging includes the mammogram, and essentially what is being looked for on the mammogram is asymmetry with very definitive borders, asymmetry between the two breasts, looking for any architectural distortion of the breasts. The nodule will be more radiodense and more irregularly shaped and unclear margins in the cancer lesion. And finally, the calcifications are irregularly shaped and they're clustered in various sizes, indicating some atypical cells and or structures, and that would then indicate that we need further testing. Okay, other breast cancer diagnostic testing includes the ultrasound, which differentiates the solid from a fluid-filled mass. Ductal lavage, which is just what it says. It is the installation of fluid into the ducts to clean those out and get some breast tissue cells. Galactography or ductography, excuse me for butchering that first term, is used in the presence of serous or bloody nipple discharge without a palpable mass to visualize an intraductal lesion. And finally, biopsy is going to be performed for definitive tissue diagnosis. So, looking at ductal carcinoma in situ, or those breast masses with some atypical cells at various stages of being atypical. So ductal carcinoma in situ. It's also known as intraductal carcinoma. And in this case, the abnormal cells are confined to the ducts of the breast. The DCIS is associated with microcalcifications, rarely associated with a palpable mass. And it's questionable, is this really a precancerous lesion? And in fact, just this summer, a group of experts have come out and recommended that we no longer call this carcinoma because that term cancer or carcinoma just sparks so much fear in most people that they're wanting to decrease the diagnostic workup in many of these cases and decrease the fear and the demands that may be made on the patient who presents with breast mass. So with putting that aside, and I'm not sure whether that's going to happen, this group actually came up with a long list of different cancer or precancerous lesions that they want the terminology changed so we don't even call that cancer any longer. Now, ductal carcinoma in situ, which is misspelled in the header up here, is usually diagnosed in association with microcalcifications that are seen on mammography. The likelihood of progressing actually to an invasive cancer is unknown. So will the ductal carcinoma in situ actually progress to a full breast cancer? Then we really don't know the answer to that yet. Oops, went too far. Okay, with this case, there is a potential for malignancy, but it doesn't have to become malignant. And 98% of patients with DCIS are actually cured or have the 5-year cure when just treatment is with a local regional therapy, such as a total mastectomy or breast-conserving surgery with some radiation therapy. Invasive breast cancer, this is where we're getting to the malignancies that strike the fear into every woman, that have the ability to metastasize, and in some cases to metastasize fairly easily. Infiltrating ductal carcinoma is where the malignant cells escape from the confines of the ducts and infiltrate into the breast parenchyma or breast tissue itself. Common areas of metastasis of the infiltrating ductal carcinoma include the regional lymph nodes, which should be no surprise because the lymph drainage is going to be right into the axillary lymph nodes. Other areas common for metastasis of the ductal carcinoma include the lungs, the skin, the bones, the liver, and the brain. Now, infiltrating lobular carcinoma is actually less common. It may present as a discrete mass, may present as thickening or induration of the breast itself, and with the infiltrating lobular carcinoma, unfortunately, it's often bilateral. My goodness, this is so sensitive. With the infiltrating lobular carcinoma, the margins of the mass are very diffuse and ill-defined, and the infiltrating lobular is very prone to metastasis. It has a propensity for being bilateral and multicentric with a 20 to 40% risk of subsequent invasive cancer. It is managed with close surveillance and a total mastectomy or chemoprevention such as tamoxifen. Paget's disease is a rare form of breast cancer. It is, with the Paget's disease, the manifestations are this, or is the eczematous nipple changes, and about 50% of women who present with a palpable mass of DCIS or invasive ductal carcinoma may also have some degree of Paget's disease. And this is what Paget's disease looked like. Notice that the areola around the nipple is very irregular, and it is very rough in nature if you were to palpate that. So that's Paget's disease. And then last I want to talk about inflammatory carcinoma, which is rapidly progressive. It causes diffuse inflammatory changes of the breast skin. So you're going to see all those signs of inflammation such as erythema, warmth, skin thickening, and then that term that I know that you all remember because the pictures are so outstanding is the peau d'orange. And with the inflammatory carcinoma, there may be a palpable mass. So this is what peau d'orange looks like. It actually looks like this breast is now an orange. Prognostic factors related to breast cancer should, again, be no particular surprise. Lymph node size, the smaller the lymph nodes, the better the predicted outcome. Tumor size, the larger the tumor size, the worse the predicted outcome. Histologic differentiation, and what histologic differentiation means is that how differentiated are the cells. Those cells that are so undifferentiated, you can't tell what the primary cell was, are far more likely to be a metastatic malignant disease than in the case where we have a well-defined cell that we can determine easily what the origin of that cell was. So those are more likely to be the more benign disease. HER2 is also a prognostic factor. HER2 stands for human epidermal growth factor receptor 2 positive. And what this is that we have an overexpression of the HER2 occurring in about 20 to 25% of all breast cancers. And unfortunately, when HER2 is present, it tends to be an indication that that breast cancer is going to be more aggressive. An excellent prognosis with breast masses and breast cancer is the DCIS, negative lymph nodes, or a tumor size that's less than 1 centimeter. Management for breast masses should be for primary care providers referral when we have a diagnosed or a suspicious case. That we can't just say this is fibrocystic changes, then referral would be appropriate. And management may be surgical, it may be radiation therapy or chemotherapy, might be hormonal in the form of tamoxifen, or it might be monoclonal antibodies, which to me is fascinating that we have now are treating the breast cancer with the monoclonal antibodies, and the antibodies themselves are attacking the abnormal cells. I need to change something on my controls here because they're so sensitive. This concludes the presentation on common breast complaints. I know that I went through the breast masses fairly quickly and without a lot of specifics. But again, a lot of what we're going to be doing as primary care is to recognize, to recognize that a breast lump is there, start the workup to determine the significance of that breast lump at the same time that we're starting a referral process to either a breast center or to a breast surgeon.